Thanks, everybody. Well, it's my pleasure to introduce Dr. Richard Hertle today, who's the Chief of Pediatric Ophthalmology, and Dr. Boomer and Jill Bernstein endowed to hear chair in pediatric ophthalmology at Akron Children's Hospital. He's also professor of surgery at Northeast Ohio Medical University. He's an investigator in the areas of nystagmus and eye movement disorders and received his bachelor's degree from the Ohio State University and his medical degree from Northeast Ohio University's College of Medicine. Following medical school, Dr. Hertle completed fellowships and residencies in ocular motility, emergency medicine, ophthalmology, and pediatric ophthalmology, and strabismus at a variety of medical centers around the country. Came to Akron in 2010 to grow the pediatric ophthalmology service after 6 years as chief of pediatric ophthalmology and strabismus at Children's Hospital Pittsburgh and professor of ophthalmology and bioengineering at the University of Pittsburgh Medical Center. He's been the principal investigator on several NIH-funded research projects, including ongoing studies on the treatment of strabismus, nystagmus, and amblyopia. An avid researcher and publisher, Dr. Hertle has over 200 peer-reviewed publications and almost as many abstracts, editorials, reviews, and invited lectures. He currently serves as a reviewer for multiple journals and has received over $1 million in research funding. Please welcome Rich as he presents today a story of change and discovery. What was learned from studying nystagmus in infancy and childhood?
Thanks, Dave. And Alex, my good buddy, thanks for inviting me to come up here on my way back to Philadelphia. Thanks for all of you for being patient. And thanks for coming to listen to a talk on nystagmus. I know this is the most exciting topic to listen to. How many of you have seen a patient with nystagmus? Raise your hand. How many of you never want to see a patient with nystagmus again? For most of you, keep your head. Hopefully this will make it a little easier. I just wanted to introduce the hospital and the division where I work, just to give you a sense, because we all know each other maybe by name or reputation. And just to show you, Akron's Children's Hospital is a large 350-bed hospital with 2 campuses, another 200-bed hospital in Youngstown. And this is the vision center that we have here. You can read all this yourself. And we're in 8 locations now. We see about 23 to 25,000 outpatients from 30 states and 30 countries. We take care of 6 neonatal intensive care units in Northeast Ohio and see 1,000 consults. And that's exclusive of 1,000 emergency room consults. And we do about 13 operations a year of 4 surgery centers, including an adult surgery center where we do adult strabismus. And this outlines our general goals. These are kind of our true north goals. You see where we have optometry, ophthalmology, education, and vision science, and the separate components within that we do. So we're kind of a full service vision center. We try and have service the entire community of northeastern and northern Ohio. We try to say no to no child, and we try to keep every child with every disease in-house so they can benefit from the support of a children's hospital environment as you have here. So if you have any kids in that area, you know that there's a place they can go to get cared for. What I'm going to share with you over the next half hour or so, 40 minutes or so, is kind of a story more than describing a disease. And the story involves looking at this group of patients for over 3 decades, both myself and my colleagues, and share with you how we came to understand a little bit more about this problem, how we came to interpret what we saw and introduce new therapies, and also how clinical basic science and direct observation can help patients and how modern science can be used. We have an LLC that has a patent on this new drug, which I'll discuss later. Just wanted to make you aware of that. These are the people who've helped me over the years, including our 2 canine friends up there. This is Ginger and Scout. Ginger, you'll see more pictures of later. She lives with us now, and Scout lives with a patient of mine in Montana. Most of the information, if not every piece of information I'm saying today, is in a textbook that Lou and I wrote, which is available free online. The publishers are gone, they've disbanded, and the book is available free. You can go to the Lab, which is at Case Western, and download the whole or parts of the textbook if you wanted to look or refer to any of this. And it's really broken up to a basic science and a clinical section. So the first part about nystagmus is, what is it called? How is it classified? And how do we name things? And I've had a pet peeve for years about how things are named. So this is an older classification for nystagmus, which you can see sometimes it still remains in some textbooks. It uses a lot of eponyms and visual descriptions, clinical descriptions of the nystagmus, which may or may not be meaningful. They're hard to translate and they're hard to communicate, and certainly hard to do research on if everyone doesn't agree on it. The other problem is not all of the eyes that wiggle have nystagmus. There's a whole group of eye movement abnormalities that are fast eye movement abnormalities that are completely different neurophysiologic, that are not nystagmus. Nystagmus is characterized by a slow eye movement system abnormality. Nystagmus always has a slow phase component as part of his oscillation. If the oscillation only has fast phases, then it's a saccadic oscillation intrusion, which is a completely different disorder. So when Kogan, Dave Kogan, I don't know if many of probably the younger docs don't know who he is. Dave probably knows who he is. Brilliant neuro-ophthalmologist who was named one of the greatest ophthalmologists of the 20th century. And I had the chance to meet with him when I was at NIH. And he, in the 60s, helped ophthalmology tremendously by taking kids with nystagmus and saying there's a group of kids who have nystagmus who can see, and then there's a group of kids who have nystagmus and they can't see well. So they must have a sensory nystagmus and a motor nystagmus. So he called the term congenital motor nystagmus and congenital sensory nystagmus. And that terminology has been passed down and used in textbooks and the board manuals since his initial description in 1968. In 1974, Dave Kogan wrote a letter to Bob Daroff, who was one of my mentors in Cleveland at Case Western, after Bob Daroff and Lou Deloso presented a paper at a neurology meeting showing that kids, little kids who could see and little kids who couldn't see, both had the same exact form of nystagmus. They were not different. Dave wrote a letter essentially saying, my classification system is wrong because it's the same type of nystagmus. And people in 2024 say congenital motor nystagmus. Still use the term. The person that invented the term said don't use it, and we still use it. This is how silly classification systems can be and how persistent they can be used. And I think naming is important, classifying is important. So what I was frustrated by this, as you can tell, I'm still frustrated by it. So when I was at NIH, we got a whole group of national multidisciplinary personnel involved in the study of eye movements together, which was supported by the NEI, to classify eye movement abnormalities and strabismus, and it's called CMAS, the Classification of Eye Movement Abnormalities and Strabismus. And it's an 85-page report, and it's a multidisciplinary collaborative classification that attempts to unify this classification for physicians and colleagues and scientists who want to do research. Where if you've ever been in a room, any of you who've ever done clinical trials, interventional clinical trials, everyone comes in with their own idea of what the disease is, right? Oh, I know what disease is, just ask me. Want to know what age-related macular degeneration is? I'll tell you. Here's the classification system I use. They had just as much of a fight when they started doing that. Diabetic retinopathy, ROP. It took a month to agree on the classification before they even could start the interventional trials. So what we did here was we came up with the classification system that could be used for interventional clinical trials. It could also be used clinically too. So I'll be using the CMAS classification today. And it's available here. You can get it online if you want as a PDF. It's also in published forms. So based on the CMAS classification, I'm going to discuss the three most common forms of nystagmus seen in infancy and childhood and leave out neurologically significant forms of nystagmus, those associated with serious brain disease, spinal cord disease, toxicity, inflammation, tumors, trauma. And I'm going to talk about these here, which are neurologically insignificant forms. And that's the terminology I'd rather use than benign, acquired, or non-acquired, because as I've discussed before, INS is acquired. So we'll discuss these three. But before I talk about them, there's a couple of peculiarities in the evaluation of these kids that I think that lie outside the routine examination that are important in the evaluation. And these are to ask other family members if anyone in the family's eyes wiggle, because family members don't always volunteer the information that we think is helpful, and we have to probe. And this is especially true in genetics, but in all of pediatrics, it's important to ask the family members. Ask them about the child's behavior when they go from light to dark and dark to light. It's very important. You'll be able to pick up more retinal disease that way. And we do ERGs as well, but if you don't have ERGs, you can tell a lot about whether or not they can adapt to dark or not, dark or light adapts. And also ask them about growth and development since birth. We recently have presented a paper showing about 18.8% of patients with INS will have some form of developmental gross motor or fine motor delay. And in those patients, 90% of them may have a neurological diagnosis associated with them. So you want to ask if they're reaching their milestones. And, asking a parent if their child is delayed is asking to get shot in the head, So I usually would say, are you or the pediatrician concerned about anything that's going on with your child? Is there anything, are they meeting all your expectations or the pediatrician's expectations? Usually that allows them to discuss the fact that their head is in the 30th percentile, 300 percentiles, without feeling too bad about it. When you examine these patients, again, these are a couple of peculiarities. It's important to check their vision, and I was very happy to see that today in the presentations that the visual acuity was recorded under binocular conditions with their refraction, allowing their head to be in free space. That will give you their binocular best corrected vision, which is their vision as a person, not their vision as an eye. If you can, check their CS, their contrast sensitivity. There's plenty of commercially available contrast measures around. It's easy to do. It's a great way to follow the kids, especially if you're going to treat them. And check their vision with their heads to the right, left, up and down, or in and out of the null position. It's a great way for you to confirm that the nystagmus itself is in fact assisting with visual function. And it's also a great way to show the parents why they're turning their head. See how much better they see when they do this, even if they don't turn it all the time. And I talked about observing for 5 minutes because of periodicity. And this is something we recently discovered. We published this paper about 2.5 years ago. About 75 to 80% of patients with infantile nystagmus and an anomalous head posture will have anomalous egocentric localization. What I mean by that is if you take their head, you can do this clinically, and you straighten it. You ask them, does your head feel straight or crooked? 75 to 80% will say it feels crooked. So their brain has rewired their head and neck and back position in space to think that this is normal. There's also some neuromuscular changes. And if they have this, then that can explain a recurrence of the head posture after treatment. The neck muscles being shorter and they have anomalous localization. So what I'll do with these patients who have this after treatment is prescribe 3 months of physical therapy. So they get to do some neck therapy. And if you do this early, that can reverse some of the anomalous localization. So the way we were able to learn all this is because of eye movement recordings. And these are the sophisticated scleral search coil lenses, which we don't use. That's the old compact EOG. This is a remote infrared. And what we use now are the remote video recordings. And this is what we use here. And this can be used by anybody. It's not the use of this that's difficult. If you can set up an OCT in your office, you can set up a automated keratometry, a visual field machine. You can set this up. It's really not setting it up and doing it. The kids, nothing touches the eye. It's done remotely. It even can cancel head posture in babies. But what's the problem is this. When you get the output, what do I do with it? So getting the eye movement recordings is not the problem. It's very easy. Any ophthalmologist office can do it. The interpretation turns out to be not that difficult either, because what you really want to be able to look for is the individual waveform. What's happening when the eye goes back and forth? Up is right and down is left. If you can see, to your upper left and upper right are the simplest back and forth the eye can do. The eye can go back and forth like a pendulum, just like a pendulum hanging from a grandfather clock. Or it can go back up in a linear fashion and back in a linear fashion. So it goes fast in a straight line and slow in a straight line. Fast in a straight line, slow in a straight line. Or it could go slow with increasing velocity or slow with decreasing velocity. I know, now I lost you. So I'm going to show you the slow phase metaphorically. So if I'm getting on the freeway here, I'm accelerating on the freeway, that's increasing velocity. So at the end of my fast phase, if I'm accelerating away from the fast phase, that's increasing velocity. If I'm decelerating and getting off the freeway, at the end of the phase, I'm getting off the freeway, decelerating to decelerating fast. Increasing velocity is INS. Nothing else causes this, nothing else. And there's about 8 different forms of increasing velocity that you get, but they're all increasing. Decreasing velocity can either be neurologically significant or fusion maldevelopment nystagmus. And linear is usually acquired nystagmus. And pendular can be INS or neurologically significant. But it's pretty, you know what, basically in the last 30 seconds, that is the essentials of eye movement recordings for clinicians to say, look, do I need an MRI or don't I need an MRI? If they have an increasing velocity waveform, you don't need an MRI unless you find something else neurologically. Then you're going to get an MRI anyway, even if they didn't have nystagmus. So you can eliminate the need for an MRI just by looking at the slow phase. The other characteristics, yes.
How well can you see that on exam?
You can't.
Just curious if you ever.
The eye is moving
I'm
at
talking
5
about
times
you
per
after
second.
seeing
I
something.
can't see it. Yeah, I can't tell. No, the you know what? The clinical exam for me has become less important. I do, you know, I look for even periodicity I can see. Even the eccentric null gaze I can see. So that using eye movement recordings, you can detect all of that. It gets a little more complicated. It's like, how many cardiologists listen to the heart anymore? Really, I mean, they do because the patient wants the hands, but they go looking at the EKG and the invasive, right? And that's what they look at. How many glaucomatologists look at the optic nerve? I mean, on the patient. They look at the OCT and they look at the photo and they look at the field, right? So they use technology to do it. You know, we got it from the patient, but they don't. I don't think they do this much with 90, 70. Sometimes, maybe sometimes. You guys will tell me. You residents will. So these are the other tests we do in these patients of the remember they have an efferent system problem, but many of them have an afferent system problem from the retina all the way back to the brain. So to detect those things, we have to check their visual functions with optotype testing, contrast sensitivity. This is the Retival. We also use VEPs. I'll use color vision testing, visual field. This is the handheld by oxygen OCT, which is really valuable because it's 70,000 hertz, so that the nystagmus doesn't interfere with the quality of the image, which it does with some of the Cirrus machines. But one of the fundamental differences of patients with nystagmus is they have a dynamic visual system. When you and I look around the world looks pretty much the same to us. I could change the illumination, but if I move my head or if I get really upset, or if you give me a medication, unless I'm completely knocked out, the world is going to look pretty much the same. But if you take any one of those parameters, acuity, contrast, motion, how fast their visual system reacts, what their vision is the function of gaze, and you look over time, just have them sit there, get them angry, get them hungry, just get them sleepy, get them emotional, and their visuals, that's going to change. They never have the same vision minute to minute. So a static measurement of their visual function with one eye covered tells you nothing about how they function. The only way to tell, it's like checking an instant blood sugar or an instant level of hormones, although it's valuable, it's helpful, it's not the same. So they have a dynamic visual system in the same way that many other physiologic parameters in our body are dynamic. And I think this is a key concept for ophthalmologists to understand because we don't think of vision that way. When we measure the visual system, we measure it and think of it as static. This is if something changes in the visual system of a patient, then it must be pathologic because it needs to be static. But these patients don't. And that's their normal. They have a period of time where their visual system is the best and functions the best. And they have a period of time where it functions the worst. And they vacillate between these two periods all day long. So if I'm in net and a 40-mile-an-hour slap shot's coming at me and I'm 10 years old and my visual system's not functioning really well, goal, red light goes on. But now, 5 minutes later, that same guy comes down and shoots, and now my visual function is the best, I make the save. So I'm the GOAT or I'm the hero, depending upon where my nystagmus is. So their visual function in school all day long is changing. And I can tell you, just to head this off, the goal of treatment is to give them their best visual function more of the time. That's the goal. If they can spend more of their day with their best vision and the families and the patient and the school and the people around them understand they have a variable vision function, then life is better for them. But we need to understand that first so we can communicate to the families and the patient. I always get asked, which patients need an MRI or neurologic? This is my algorithm, this is all published. I don't want you to commit this to memory, but basically, the point of this is that eye movement recording can be the single most important way to eliminate the need for unnecessary neurological investigation, including MRIs and tests. Eye movement recordings can really the center for that algorithm. All right, so this is the CMAS box for INS, which you can read here. It has a major criteria, associated findings, general comments. It's a living system, so things can change. This has a pathognomonic diagnosis, which is accelerating slow phases on eye movement recordings. But these other characteristics you'll see written in many textbooks about infantile nystagmus syndrome. But it has a very peculiar associated phenomenon, which we only discovered with the use of eye movement recordings and over time. If you watch this young woman, you'll see she has an esotropia with when you do cover on cover. But if you watch her nystagmus, she has a slowly and spontaneously increasing intensity. Just spontaneously, it starts getting worse. She's not doing anything different. She's not in a different environment. This is all internal. And if you do eye movement recordings on her, this is what you see. This is a regular 90-second rhythm of jerk right, nystagmus, slow down, stop, jerk left, slow down, stop. Totally regular. I don't know of any neurology, advanced neurology, any other rhythm, heart rhythms, GI rhythms, peristaltic rhythms that have this regular. And this is pathologic. Maybe it's not. Maybe it's actually suppressed and it comes out in certain situations. This is called pure infantile periodic alternating nystagmus. You can see this in the acquired form when certain neurological injuries around the floor of the fourth ventricle and near the chiasm with trauma. So you can see acquired periodic alternating, but this is infantile. And unless you look at the patient for 5 minutes, because this was 90 seconds going in one direction or the other, you're not going to see this. Most often it occurs aperiodically, and I'll show you that. So how do we look at the pathophysiology? And I'm putting up there just to ignore it, but to show you how we analyze why nystagmus is taking place. And what happens is, this is a control systems model. This is one way of looking at this. Many ways of looking at brain function. One of the ways that those of us in the engineering world look at brain function is like an electrical system, a feed-forward, feedback system. And you can do control systems analysis and make computer modeling of nystagmus. And we've been able to generate the waveforms of infantile nystagmus on computers using this model. This is a model that Lou Deloso published back in one of his versions of this. And what we think is happening is there's a poor calibration in the smooth pursuit system. And smooth pursuit is the ability to follow a moving target. And you can't do this voluntarily. There has to be a moving target. And we believe that smooth pursuit at zero velocity is gaze. So straight ahead gaze, not moving, is smooth pursuit at zero velocity, which is uncalibrated. So that's the control systems model. Now I'm going to give you kind of the bigger picture metaphorical model of why these kids have infantile nystagmus. So I have development of the efferent system from birth on and development of the afferent system from birth on. And the metaphor that I use is two trains traveling parallel to each other on two train tracks. And one is the afferent train, and one is the efferent train. And they have their own track, their own destinations, their own motors. Everything about them has developed individually. So they have individual components. But what they do more importantly than going down the train is they communicate with each other. Imagine these two trains now, all the passengers in the afferent train and all the passengers in the efferent train are holding hands with each other. And that's the communication between the two trains. What the brain mostly does is talk to itself. We think of the brain mostly as providing sensory functions and feelings and emotions and our interpretation of gathering information about the world. But the brain mostly just talks to itself. And this communication system that develops between the afferent and efferent system is finely tuned. And it actually expects input from these two systems in order for it to develop properly. So I'll give you an example. If you cut this communication between 1 and 4 months of age, you get infantile nystagmus. And the classic example is bilateral complete congenital cataracts. So in the womb, there's no reason for light to help with development here. There's no need for that. It doesn't happen. The brain doesn't use it. And so after birth, it becomes important that the visual system, the afferent system, be stimulated in a certain way for the communication to continue. But it's not in congenital cataracts. And so usually somewhere around 5 or 6 weeks of age, 8, 10, 12 weeks, they get nystagmus. And if you record the nystagmus in these patients, it's always infantile nystagmus. But if we operate on these babies in the first 4 to 6 weeks of life, before the full development of the nystagmus, and have these systems reestablished, the communication systems, then the nystagmus not only doesn't develop, it can go away. So this shows the importance of this critical period in the eye movement system between 1 and 4 months of age. So that's when this breakdown occurs, and that's where you get INS, is this lack of communication. It's not aniridia, it's not achromatopsia, it's not albinism, it's not retinal diseases that causes the nystagmus. It's a motor system disease that's the result of brain problem, a communication system disorder in the brain. In the same way that we say amblyopia can be either associated with anisotropia, with strabismus, with deprivation, but the amblyopia itself, the physiology, the pathophysiology of amblyopia is in the lateral geniculate and the cortex, not in the eye. It's not the eye that's causing the disease. It's the brain's problem. Because if you give an adult deprivation or anisotropia, the brain doesn't respond the same way. It's the same thing for infantile nystagmus. Even though they say the cause of congenital nystagmus is aniridia, that's not the case. The association of infantile nystagmus with aniridia is due to the developmental disruption in the communication between the developing afferent and efferent system. I hope that makes sense, because that's what we understand. Fusion maldevelopment nystagmus is probably more recognizable to most ophthalmologists. It's usually almost always associated with infantile esotropia, dissociated horizontal and vertical deviations, and it's characterized by a horizontal nystagmus. It's actually torsional. It's multiplanar, and it's exacerbated with monocular cover, and it changes directions. And you can sometimes differentiate this from, I'll show you, from infantile nystagmus that can also look this way. So here's a young woman who has a bit of a face turn and a small angle esotropia. And when you do alternate cover testing, you'll see the esotropia and you see the latent component. It's pretty easy to see here because it looks like she's quiet, right? Under binocular conditions, she has no nystagmus, and then when you cover it, she has nystagmus. That's what it looks like. But when you record her, this is what you find. She has nystagmus under binocular conditions. There's no such thing as latent nystagmus. They all have nystagmus under binocular conditions. You're just not seeing it with the naked eye. So it's not gone. Latent nystagmus vera is very rare. That's latent nystagmus vera. It's very rare. So in the binocular conditions, she has jerk left. She likes her left eye, which gets worse when you cover the right eye, and then gets much worse when you cover the left eye because she prefers her left eye. So this is fusion maldevelopment nystagmus. Here's a young man who had ROP and high myopia and moderate to large angle esotropia. And when he fixes, he had what looks like latent nystagmus too. And he likes his right eye better. Cover the left eye and you see he has jerk. So he must have fusion maldevelopment nystagmus too. But when you do recordings, he has increasing velocity exponential slow phases that get worse, jerk right with the left eye and jerk left with the right eye covered. So he has infantile nystagmus with the latent component. Two different diseases that look the same, and the treatment is different. And the only way to distinguish these two is with eye movement recordings. They look exactly the same. And spasmus nutans is the last disease I'll discuss here, and it's almost always benign. Having said that, there are cases where people have seen this associated with optic pathway tumors, but it's a high frequency disconjugate, 180 degrees out of phase. Right eye is going to the right, left eye is going to the left. 10 hertz oscillation associated with a particular form of head bobbing that's different than the head oscillation associated with infantile nystagmus, which I call nystagmus, which is this. but this head bobbing is different. And these kids have an asymmetric high frequency oscillation. When you see this combination, they don't have tumors. But it's hard to see this combination if you don't have this. So all these patients get MRI. And sometimes you'll see what looks like spasmus nutans, but it's actually acquired pendular nystagmus. It's a high frequency asymmetric nystagmus that looks a lot like this. So I don't have any problem with, if you see a patient that looks like that with asymmetric high frequency nystagmus as a baby, that you get an MRI, there's no reason not to. It's better to be safe than sorry in that situation. These are all the things that go wrong objectively and subjectively. I won't read them with patients with nystagmus. All of these problems. The nice thing about listing them is many of them can be treated. These are just some data from thousands of patients I'm sharing with you, which we published a couple of years ago. And I think some of the things that stand out are the large number of patients who need glasses and who have strabismus associated with this, and untreated amblyopia in a third of patients. Because they have nystagmus and a head posture and strabismus and they have retinal disease, no one thinks to patch them or to treat the anisymmetropia. And any other eye disorder, including ALMA, is in 2/3 of these patients. It's getting more and more as we do genetic testing. If you use genetic testing, you can get up to 80%. Systemically, you can see as much as 45% of patients will have something systemically to look at. All right, so this is what I was talking about with head postures. Here's two patients with a head posture, a patient I saw in China, and then this is a patient we saw locally, and that's the clinical head posture. And this is the differential diagnosis in nystagmus patients, why they can have a head posture. It's not just an eccentric gaze null. So here's the static gaze angle reason. So the null position is to the left, their head is to the right. But if they converge and they null, then they won't have a head position. Depending on which eye they fix with, their head position may change. If I have a latent component and I cover the eye, it's going to be worse when I look over here. So I'll turn my head like this when this eye's covered, and turn my head like this when this eye's covered. So depending upon which eye is fixing, the head will look differently. Imagine if they have dense amblyopia in one eye and strabismus, and they have a latent component, they're always like this, and you think they have a gaze null, but it's actually not. It's a latent null. Their null position changes if you stimulate them with smooth pursuit or an OK head drum. The null position goes in the opposite direction. Don't ask me why. We don't understand that. And they may have periodicity. You saw that girl who's actually changing her intensity. So when it's really intense, jerk right, and she wants to look at the world, she'll go like this. When she's really intense, jerk left, and she wants to look at the world, she'll go like this. I've seen kids who have been operated on because they had a right face null, and the surgeon went in the next day, then at the surgery, and said, I wrote right, it's left. She's there left now. So you have to really be careful with periodicity. If they have bad vision in one or both eyes, if they have bad vision in both eyes, they won't use their eccentric null position. They may only use it in one eye. If they have associated strabismus, say I have a couple of INS patients with Duane syndrome. So they have esotropia and Duane syndrome in this. And is there a problem with their neck or egocentric localization? So it's not just as simple as their head position. So how do we treat this? We can treat the underlying etiology, which we talked about with congenital cataracts, messing with the system. We can treat the sensory system, the motor system, or we can, in this group of puppies, these puppies had RP65 defect that we worked with at so I've been working with these dogs for a long time. There's another one up there. He's a really famous one. These puppies had subretinal injection of RP65. They have hereditary Leber's congenital amaurosis. And here's the puppy after weaning. They had the injection. If you look at the eye before and the eye after, it stops wiggling. So treating the retina and improving vision is just like restoring the vision with congenital cataracts. So that's treating the underlying etiology. We can't do that most of the time. So what we can do is give them medications that reduce that. We talked extensively about that. I won't go into it again. Optical treatment is extremely important. It's very powerful for the brain to give them optical treatment. And these are the variables. And I discussed how contact lenses help tremendously. And non-traditional treatments are important. We talked about This is the Gabor, it's called Revital Vision. I've been working with these people out of Israel. And not only amblyopic patients, but patients with nystagmus have been using this technique of looking at Gabor pictures, and some about 25% of the patients seem to have improved visual function with this. And now I have an idea of why they may be helped. The acupuncture has been tried. Biofeedback meditation is really important. I suggest to all my patients that they practice mindfulness meditation, which gets them in a calmer state and reduces the intensity of the oscillation, especially in when it's really intense. And also you can actually stimulate the brain. These are the medications that I've used. So I want to talk about surgery and kind of wrap up with that. This is Jay Anderson, and this is my copy of his textbook. And in 1959, he wrote these are his quotes. He operated on these patients for a head posture, and he found that when he did eye muscle surgery, the nystagmus got better and their vision improved. And he said in 1959 that it should not be considered fixed and treated. And even at the beginning of my training, they barely treated patients with nystagmus. So we tried to understand this, and Lou Deloso and Bob Daroff, and then John Flynn first, and then Bob Daroff, John Flynn, and Lou Deloso in the late 80s and 90s did eye movement recordings of patients before and after Anderson-Kestenbaum recessed and resected the muscles, and found that their nystagmus improved dramatically. So we wanted to figure out what was it about doing the muscle surgery that made the nystagmus better. And Lou and I found, with the help of Rob Williams, who was at Dartmouth and then moved to Memphis at the University of Tennessee. These are achiasmatic Belgian sheepdogs. You can see they have no chiasm, and they also have infantile nystagmus with a seesaw component. So we had this animal model to study some hypotheses about what eye muscle surgery did to the infantile nystagmus and how it helped. So our hypothesis was maybe it's not moving the muscle at all. Maybe it's just cutting it that helps the nystagmus. So that's what we did. We took the muscle and we just cut it and put it right back at the original insertion. And we published that study, those studies here. And then we did that same trial blinded when I was at NEI on adults and kids. And then here's some of that since then. So these are the trials of those. This is just taking the muscle off and putting it on. And this is an example of what happens electrophysiologically. The nystagmus doesn't disappear. This is going back and forth 5 times per second. After surgery, the eye's going back and forth about 5 times per second. So the naked eye looks like nothing was done. But during each beat, this is called foveation. This is where the brain actually sees. This is where the brain turns. The brain suppresses with saccadic suppression during the fast phase and efferent's copy during the slow phase. So there's 2 mechanisms of suppressing oscillopsia that the brain uses in INS. But it turns the world on during the foveation periods. And look at the difference in the amount of time. Here, maybe, out of 1,000 milliseconds, the brain is actually looking at the world for maybe 100 milliseconds. 10% of the time. So it takes 10 times longer for the patient to see something. And it's even worse if they're moving. If we go up to a 200 millisecond, that increases it by 30 to 40%. So what was it about here, cutting the eye muscle here, that caused this effect? Well, I've labeled this part of the eye muscle the enthesis. I stole that term from rheumatology and orthopedics. And it's where tendon becomes sclera and scleral becomes tendon. And I wanted to study this area, but found that no one had really looked at this area before, because pathologically, if you want to study the muscle, you cut it here and study the muscle. And if you want to study the eye, you cut it here and study the eye. So I developed an en-bloc resection technique that took off the sclera and the tendon and the muscle when we were doing a resection, and then placed the muscle over there. So we could look at this anatomically, histologically, and physiologically. And what we found was, where's my slide? Missed it. So we have a slide with a paper where we found new nerve endings, these enthesial fibers, and these fibers have been studied that go back to the brain. I think I have it later. So these, after thousands of muscle surgeries for nystagmus, I've been able to create an algorithm that any clinician in the world can use to do surgery on these patients. You don't need eye movement recordings. You don't need even special testing, even though I recommend it all, because it's really important that these kids get help and that they can get better. And so most of the children will fit into one of these 9 clinical categories with clinical evaluation. And here's the actual surgery. I even have the recipe for what works to do that. And this can be used successfully and has been all over the world, this algorithm. This is the kind of thing you see. Here's a little girl with a chin down position, which is very characteristic of albinism. And there's eye movement recordings before and after surgery showing almost complete absence of the nystagmus, except those are planes. This is a dramatic improvement after eye muscle surgery. But as I said before, single surrounded acuity is a terrible measure. What's really happening is they have an area of vision space where they see the best. And as they look to the right, left, and up and down, their vision blurs away from that. After surgery, the area of best vision not only moves centrally, but expands. And a better way for us to analyze this, I've used this over the last few years, is a measure I call gaze-dependent visual acuity. So we measure vision as a function of gaze horizontally and vertically. And if you map this out with area under the curve mapping, you can see that what we created is this area called functional vision space. And if you and I were to do this, this whole square would be white. And so the area of functional vision space before and after eye muscle surgery for nystagmus increases dramatically. But again, I had to publish acuity, so we did. This is 85 patients with OCA 1. These are the most severe forms of albinism who had eye muscle surgery and had actually all the treatment, had glasses, contacts, and eye muscle surgery, and baclofen. And this is their starting acuity on average, and this is their average post-treatment acuity after all of that. And so acuity, but contrast sensitivity got better at all cycles per degree, 3, 6, 12, 18. And here's clinical testing of contrast sensitivity before and after their treatment. And one of the things we recently found were in adults who were surgically naive, had never had surgery on their eye muscles, and with INS, there was a significant number of patients who were unable to drive before, but got enough lines of vision after surgery to drive. These are all the things that get better after eye muscle surgery for nystagmus. You can see listed there. Those are visual, and there's, I have acuity at the top, but it's the least important, I think. So the beneficial effects of that are everything we see here, independent of why you operate. And I talked about what that is, and here's the slide. These are the nerve endings, and these are the publications. And so these nerve endings reinvigorated a study of oculomotor proprioception, which had been buried and dead since the 80s. They thought it was vestigial. Oculomotor proprioception was vestigial because we have the greatest proprioceptor in the body in the retina. But since this is just a sample of, I have in the next slide, of publications, new publications. So if we're working on the proprioceptive afferent system, maybe we can affect the eye muscles and the oculomotor system topically, as well as with medications, as well as surgery. Here's a list of recent studies on the oculomotor proprioception that have just exploded since the discovery of this new oculomotor proprioceptive circuit. So this is a consequence of looking at a patient. I had a patient who said he got better when he took his Diamox orally, and we did recordings on him. Up is better, and with his Diamox on, he was better than without, with his nystagmus as a function of gaze. So we tried topical drops on him, and he got better on the drops because if the oral medication would work, it'd be better to use the drops. He wouldn't have to take anything. So these are single case reports. And then we did a double-blind crossover randomized trial with brinzolamide versus placebo. So the patients got placebo, then washed out and got brinzolamide or vice versa, showing the beneficial effects on the nystagmus with topical brinzolamide three times a day, or using the carbonic anhydrase inhibitor on the esophageal ending. Last thing is that this is Ginger, and she's Ginger and Scout. She has RP65 defect, was bred for us. And if you can briefly read this, I had a patient, an adult patient, who accidentally got a pesticide in his eye while working on his farm in Montana, and he thought he was going to go blind. Took him about 15 minutes to get to the house to wash his face and get the pesticide out. It was a new pesticide called Wario, which was developed in Canada. It was probably actually a weapon of mass destruction that we just took to kill grasshoppers. And And so he got it in his eye. Of course, he thought, this is terrible. So he goes in the house and washes it out, and it didn't hurt him too much. It was a little inflamed, but within a few hours, he noticed that he could see better. And he was looking at his eyes, and he said, my eye's not wiggling as much as the next one. So he came to see me, and it's a long story. I'm happy to tell you after, with him and his two brothers who I operated on. But we got this pesticide and made it into an eye drop. And then we checked the eye drop in the dogs. And the dogs before, for their nystagmus. Here's Ginger, right after weaning. And if you look here, you can see Ginger has nystagmus. Here's the recordings. And then after the drops, no nystagmus. And she's 13 years old with me now and still has no nystagmus. So this drop is now getting ready for a clinical trial in the Philippines after 13 years. We've had to go through, it's a long story, which I'm happy to share with you after. But this drop is now, it's going to be a clinical trial in nystagmus patients. But, not everything ends well, So this is a report by the American Academy of Ophthalmology, which I belong to. And it basically says, don't do this operation. Doesn't help acuity. That's what it said. So this is a policy statement that's supported by the American Academy of Ophthalmology, saying that that what I've shown to you now isn't important, don't do it. This is a policy statement by the National Institute of Health and Services in Britain, pretty much saying the same thing. So the Academy of Ophthalmology and the British National Health Service think that doing eye muscle surgery on nystagmus is so unimportant and so detrimental that they wrote policy statements on it, telling their docs they shouldn't do it. I don't know. So I wrote back to the American Academy of Ophthalmology, who I know these people, and I know who they are, who wrote this, and they basically, if you can read this, it's kind of fun reading, it's fine. You get a little different than science. And after I wrote my editorial back, Lou and I wrote the editorial, they wrote another response to us saying, yeah, Rich and Lou are right. We shouldn't use acuity. We should use something else to do this. This is not the right thing. And so these are the supporting documents about acuity. And so my final statement is single point, best corrective is a poor measure of the effect of nystagmus. And I hope that I made that clear today, because nothing is done in a vacuum, and I don't understand necessarily the reasons for the people being upset, my colleagues, mostly my academic colleagues, at the fact that somehow it was the same reaction that you might have had when I said we take the muscle off and put it on. There's some initial gut reaction that this can't work. But those of you who know anything about the history of medicine know that all new discoveries seem fantastical to someone at some point. And we tried to do the best science we could do. This was NIH-supported science. This is years of observation. This is multiple people doing this. And I can tell you that in places that I've traveled in India and other parts of Asia and China and South America and Eastern Europe, they have set up multiple nystagmus clinics and are helping multiple kids all the time, every day, as a result of this. And it's just sad to me that most of my colleagues in pediatric ophthalmology, even just at APOS now, the American Nystagmus Network, who I worked with, had a booth there, and I was with them, and docs were coming over and arguing with me and saying, we don't believe what Hertle says, so I'm introducing you. This science isn't always fun and rewarding, and you just have to keep your head down and keep working. But what I've shared with you today, hopefully, will entice you to look into this more. I'm not trying to make up your minds, but give you an idea of what to look at so that you can make up your own minds and keep pursuing. So if you believe you're right, and you have data and you're following the scientific method, then don't give up. Someone's going to tell you, especially you young physician scientists, something's up, or don't do something. It's not true. If you're following the scientific method and you're doing things above board and you got good mentors and good collaborators, then keep going. You'll find the truth. Thanks. Thanks for being here.
for a question or two?
So Rich, we used to, I'm a little bit younger than you, but of an age, do very large recessions, the four horizontal recti. It was probably doing the same thing that you were, but it's much easier just to do a 0 millimeter recession, safer to do that. And I agree that I try to explain to my patients and the residents is that we're centering a null point in some cases, but we're also broadening it. So patients that have difficulty reading, they've got this hill of good acuity in their null point, but it falls off much quicker than any of us would, because we can look 20 degrees this way and that way and still the same acuity. But then status patients, they drop pretty dramatically as they look side to side. And I think that's what we're doing. So I applaud all your work. I
Thanks.
love using
I
it.
think the other thing is that it takes them longer to see. That's a very functionally disabling thing, especially in a dynamic environment. So if they're in a static environment, but it's a testing situation and they have to read, it takes them longer to acquire the information. And so there are functional impairments that are not measured in our office, right? That get better when you make the nystagmus better. I haven't ever made anybody's nystagmus worse with this. You know, and people have been doing nystagmus surgery without realizing it for 100 years, right? If you take that adult albino with esotropy, just do a BMR recess, you're helping his nystagmus.
Well, I'm older than Matt. I'll tell you that, so well-kept secret that you know is that I spent 2 years with Rob Brynick between my fellowship and going to Toronto. And I was part of the eye movement team, and he was doing large 11 millimeter, 12 millimeter, he was doing this surgery, didn't realize it. That was back in the days when we put coils on kids and put them in a box, and that was crazy. Now, eye movement recordings are so easy to do, and I believe they have such an important aspect of treating these kids that we need to be doing it more. The problem is, it's expensive.
It's 40,000.
Yeah,
I mean, that's not nothing, but consider how much does a field machine cost now? I have 100,000 or something,
The problem
80,000?
is I think pediatric ophthalmologists in general don't see it as having an effective link to outcomes and treatment, when it does diagnostically. I think you showed that today.
Yeah, I think it's medicine
And
moves
by the way,
slowly.
Rob Reinick showed that
Yes.
years ago. We're talking 30 years ago.
Right, the technology is so easy to use, it's the interpretation.
Yeah.
I think if it could be as facile, I mean, a young ophthalmologist for the first time resident looking at the diagnostic reports that come out on the Cirrus screen, looking at a guided progression analysis of the optic nerve, can read those numbers, right? You can read the thickness of the retina. All of that stuff comes out and so easy. You can't do that with this unless you're trained in it, right? But if those numbers could come out with this, then it would be more useful. And I'm hoping that relationship, they want to do it. And I have thousands of iMoon recordings to help them. And now we're contracting with some AI specialists. But I think that's where AI really can help, because they can go through the waveforms, go through this really quickly.
You can do an EKG. EKG reads itself. That's what you need.
Yellow red's very nice to look at.
Well, it's fantastic.